Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This webinar is held in honor of Breast Cancer Awareness Month and is titled Updates in Breast Cancer Care. The presenting providers are Trinity Health IHA Medical Group Breast Surgeon Tara Breslin and Trinity Health IHA Medical Group Medical Oncologist Radhika Takiar. Welcome.
Thank you, Allison. Thank you for being our fearless leader, putting this webinar together and keeping us organized. And I really appreciate the opportunity to speak with this group tonight. I apologize for my cheap extra reflective glasses, but I do need to be able to see the screen. So I'll take them off occasionally just so it doesn't look too scary in this Halloween season. But I am a breast surgeon. I've been practicing as a breast surgeon for 25 years, and this is my 9th year working at Trinity Health and IHA Medical Group. And I'm really happy to be speaking to this group tonight about basically what's been the focus of my career for 25 years and why I enjoy coming to work every day and working with our wonderful multidisciplinary group. So I'm going to start with a brief introduction, really kind of describing what breast cancer is, how we talk about it. I'm going to talk about surgical care, and then I'm going to slip in just a little bit of information about survivorship. And then Dr. Takiar is going to talk about systemic therapy. And then we'll take your questions at the end. In the United States, breast cancer is, there are approximately 230,000 new breast cancer diagnoses for invasive breast cancer and about 70,000 new breast cancer diagnoses for non-invasive breast cancer or ductal carcinoma in situ. You can see that the prevalence or the incidence of cancer varies by state. So some states such as Wisconsin and Minnesota have a very high breast cancer incidence, whereas other states such as, these ones over here that are all rectangles, they have lower breast cancer rates. Here in Michigan, breast cancer incidence also varies by county. And we have a fairly high incidence of breast cancer in Southeast Michigan, with lower incidences on the Upper Peninsula. Now, the risk of breast cancer is primarily related to being to female gender and increasing age, but there are other risk factors which modify our breast cancer risk. The highest risk individuals are those who have a prior biopsy that demonstrates either hyperplasia or a condition called lobular carcinoma in situ. Certain inherited conditions such as BRCA1 and BRCA2 mutations, and a personal history of breast cancer at a young age. Other moderate risk factors, which increase the risk from about 2 to 4 times the population risk, are also associated with the higher risk of breast cancer. But again, most of these are not modifiable risk factors. Having had a history of ductal carcinoma in situ is not really something you could change. But there's a large list of potentially modifiable risk factors, which can both increase and decrease breast cancer risk. And some of those modifiable risk factors are the amount of alcohol you consume, whether or not you develop obesity after menopause, personal history or lack of physical activity, and type 2 diabetes. And those are all modifiable risk factors which we can impact by changing our lifestyle. The anatomy of the female breast is important to understand so that you know where breast cancer comes from and what structures surround the breast. The breast is made up mostly of fatty tissue, and then in between that fatty tissue, there's glandular tissue. The glandular tissue is made up of milk ducts and milk lobules, And that's where cancer comes from. And the breast sits on top of the pectoralis muscles and underneath an envelope of skin. Surrounding the breast are lymph nodes. These lymph nodes lead to lymphatic channels, which then drain into lymphatic chains, usually under the arm, but also along the breastbone and further down the body. But the most common place for breast cancer to spread, if it does spread, is to the lymph nodes under the arm. There are two main categories of breast cancer. There is ductal carcinoma in situ, which is a non-invasive breast cancer, which is comprised of a proliferation or overgrowth of abnormal cells within the milk duct. This is a precancerous condition, and it does not spread to other parts of the body. Invasive breast cancer, it includes those tumors where the cancer cells have gone outside of the milk duct or the milk lobule, and therefore they have the potential to spread either through the blood or through the lymphatic system. And that's why breast cancer care is multidisciplinary and not just a surgical approach. We talk about breast cancer in terms of stage. So we describe the tumor size, whether or not it has spread to lymph nodes, and whether or not it's spread to different parts of the body. And there's stage 0, which is ductal carcinoma in situ, stage 1, 2, and 3, and then stage 4, which is metastatic breast cancer. And we may be using these terms throughout the talk. Breast cancer has the highest incidence in about the 7th decade. And that's true for all races. And the highest incidence of breast cancer occurs in white Americans, with the lowest incidence in Asian American and Pacific Islanders. The incidence of breast cancer decreases as women get older, really dropping off in the 80s. In the early 2000s, the incidence of breast cancer actually went down for a little bit. And that is thought to be because of the decrease in use of exogenous hormone replacement therapy. But over time, the incidence of breast cancer has gone up for all racial and ethnic groups. And we think that that is because of increasing rates of modifiable breast cancer risk factors, such as type 2 diabetes and postmenopausal weight gain. Breast cancer, oh, sorry, I've got a little bit blocked here on my screen. Okay, I didn't want to miss male breast cancer. About 1% of individuals who develop breast cancer are men. And again, the highest incidences are in white and Black Americans, but the highest mortality is in Black men with breast cancer. And in general, the treatment is similar to treatment to breast cancer treatment for women, but they make up an important part of our patient population, so we don't want to forget them. Breast cancer mortality, because of advances in systemic treatment, which Dr. Takiar will be talking about, and improvements in screening, the breast cancer mortality has decreased for most groups in the United States. However, you can see that white Americans have a lower mortality than Black Americans. And that is thought to be due to lower access to screening and potentially to lower use of systemic treatment. Interestingly, Native American women and Alaskan Native women have not seen any decrease in breast cancer related mortality since over this time period. So how did we get here? How was it possible to actually decrease mortality from breast cancer? This picture here shows deaths per 100,000 in the United States from 1975 to 2023, showing a substantial decrease in the number of deaths due to breast cancer. How did this change come about? Well, this change primarily came about due to results of clinical trials. There are a lot of different types of clinical trials, which can affect outcome related to cancer, specifically breast cancer. There are treatment clinical trials which ask the question, is there a new medication or a way to deliver treatment that leads to better outcomes? Prevention clinical trials are for people who've had cancer in the past or unaffected healthy volunteers. And we're asking the question, how do you reduce the risk of developing cancer or reduce the risk of cancer returning? Screening clinical trials look at new ways or improved ways to detect cancer before it becomes symptomatic and when it is the most treatable. Supportive care clinical trials are very important. They're for people with cancer to improve the quality of life in people who are undergoing treatment or who've had cancer in the past, and thinking about ways to mitigate the side effects of treatment and the long-term effects of treatment. And lastly, another very important type of clinical trial is an observational study, where we collect health data on populations of patients, or populations of individuals over time. And specific to cancer research, we're looking at which groups are more likely to develop cancer, what lifestyles and what health habits are more likely to lead to an increase or a decrease in cancer incidence. So breast cancer treatment, this is really sort of the heart of the talk here, has undergone a lot of change in the last 130 years. I've been showing this slide probably since probably since residency, but it's still relevant because the first successful breast cancer treatment was described by a surgeon named William Halsted, and he described the radical mastectomy. And that procedure came about because anesthesia was developed. So it was safe to actually put somebody under anesthesia and undergo a very aggressive surgery. And that surgery involved removing the breast, the skin of the breast, and the muscle, and all of these lymph nodes under the arm. And while this surgical treatment often gave people a short window of survival, it wasn't effective enough because there was no systemic therapy at that time. And not only that, the treatment was very, very disfiguring, very painful, and left people with many long-term sequelae, including severe arm swelling, dysfunctional shoulder, and pain. And for this reason, many people were still afraid to come to the doctor to even tell them that they might have a breast lump. Over time, and you can see the next real change in surgical therapy was almost 100 years later. And we'll go over all of these. This little green dot is when I started medical school. So you can see there was a lot of years before and a lot of years since, and a few years since then. But really the major clinical trials which changed the way surgical care was offered to women with breast cancer and men with breast cancer really came about before 1990. So the first sort of groundbreaking clinical trial in breast cancer had the acronym NSABP-B04, and that doesn't really matter. The name of it isn't that important, but they asked the clinical question, can we do a less radical mastectomy? Can we do less so that people have better function and have a better life after this surgery? And what they did was they compared groups of women with similar sized tumors, and they compared treatments of radical mastectomy with total mastectomy plus radiation of the lymph nodes. And they were asking, is survival any different if you have is survival better if you have a bigger operation? And the answer was no. What made the difference in survival was whether or not people had positive lymph nodes. And so these curves here show that the women with positive lymph nodes did not live as long without breast cancer as the women with negative lymph nodes. The next groundbreaking practice-changing study looked at the question, can we preserve the breast? Because during this time, screening mammography was developed and systemic therapy was being developed. And so patients were not only presenting with smaller tumors, but there were more effective systemic therapies. And so the research asked the question, can we safely preserve the breast? And this was really controversial. People thought this was the most radical treatment that you could recommend, was to do something less than a mastectomy that might require a skin graft. And so in this study, they compared 3 treatments: mastectomy, removal of the breast, with lumpectomy alone, which is just removal of the tumor and a rim of normal tissue around it, compared to lumpectomy, which is that same surgery, plus radiating the breast. And what they found is that in all 3 groups, survival was the same. And so that told us, or told them, that it was safe to do a lumpectomy or less aggressive surgery. And that also that there was a benefit to doing radiation, and that radiation reduced the chance of a recurrence in the breast. So these were practice-changing and really inform the treatment options that we provide to patients every day in our work. The next real change in surgical therapy came about when I was in training. And that was asking the question, can we remove fewer lymph nodes? Lymphedema is very disabling. It can change people's ability to work and function. And treatment recommendations were less and less being made based on the lymph nodes and more being made based on the characteristics of the tumors. So was it possible to actually do a less aggressive or less a less invasive lymph node surgery? And so the answer was yes. There is a procedure called sentinel lymph node biopsy, which allows us to evaluate just the first couple of lymph nodes and remove only a few during surgery. And so we reduce the likelihood of lymphedema or arm swelling, shoulder tightness, and abnormal sensation. And the way we do that is we inject the breast with a radioactive tracer on the morning of surgery, and it travels through the breast and it becomes lodged in the first couple of lymph nodes. Then during surgery, we actually use a radiation detecting probe to identify those lymph nodes and excise them during surgery. It turns a very morbid, meaning a procedure with many side effects, and usually having a drain in after surgery, to a surgery to stage the lymph nodes with just a few inches, maybe 1.5 inches long. The other possibility is that there are some patients where we don't even need to remove lymph nodes at all, because all of the decisions about the systemic treatment can be made based on the primary tumor characteristics. And so we can avoid lymph node surgery altogether. Breast reconstruction has also seen many advances. And I think last year or the year before, a couple of my colleagues gave an update on breast reconstruction. So I won't really focus on that too much, but I will tell you that in 1998, the Women's Health and Cancer Rights Act was signed into law, which mandates reconstruction coverage for individuals with group health plans. And what that means is that if you are medically a candidate, insurance needs to cover reconstruction. And there's a wide variety of options, everything from implant-based to muscle flap based. There's a area of surgery now called oncoplastic surgery, where we're doing better lumpectomies to preserve the shape and appearance of the breast. And more recently, there's been the emergence of 3D nipple tattoos, and I would have brought some photos, but I really think that you can Google those. They're really quite accurate looking, and really are much better actually than a surgical reconstruction of the nipple. Finally, I want to talk a little bit about flat closure, which as a surgeon, that just means finishing the operation and closing the incision. But for many patients, this term is important, and I understand why. Because what they're doing is they're making a choice to say, I would like to have my incision look pleasing and I would like it to be smooth. And so I'm going to choose a flat closure. That's not declining reconstruction. It's really just saying I'm asking my surgeon to do their best to make my incision look as pleasing to me as possible. And so that term aesthetic flat closure has come into use. But now, what's next? Can we actually find some patients who actually don't need surgery or who we can avoid surgery for when they're diagnosed with breast cancer? And there have been several studies recently, one looking at women with ductal carcinoma in situ or stage 0 cancer, and knowing the background that some ductal carcinoma in situ never really turns into anything. It's picked up with highly accurate screening mammography, but it might just sit there and do nothing. So do we really need to treat this like a cancer? And so there was a study where the acronym was called the COMET trial, which looked at active monitoring, meaning no surgery, versus standard therapy for low-risk ductal carcinoma in situ. And the preliminary results are that active monitoring is not inferior to standard therapy. Now, not everybody is a candidate for this. And again, these are early results, probably not yet practice changing, but there are some women with what we would call low-risk ductal carcinoma in situ who may choose not to have surgery and radiation for their ductal carcinoma in situ. Lastly, can we actually omit surgery for patients with invasive cancer? Can we actually go all the way from the radical mastectomy, removing the skin, the breast, and the muscle, to actually not doing surgery at all? And there have been a couple of studies which ask this question. And the reason that this is a viable question is that there are some patients who we actually give chemotherapy to before we even go to the operating room. And after they've completed their chemotherapy and then they have their surgery, we find that about 40 to 60% of those patients have no remaining cancer in the breast. So is it possible that we could avoid surgery in some of those patients? So a recent study that was published by researchers at MD Anderson Cancer Center and other institutions looked at 50 patients who underwent pre-surgical chemotherapy. And these patients actually underwent serial biopsies and imaging. So several times during their chemotherapy, they had repeat biopsies. And 31 of the individuals who participated in this study had no remaining cancer on a repeat biopsy. They just went on to radiation therapy and did not have surgery. And preliminary data shows that 55 months later, there are no recurrences, indicating that there may be a subset of patients at some point who can avoid surgery altogether. I think that's really exciting. And I'm going to just talk a little bit about cancer survivorship. Even though it's a little bit out of order, I thought I might have trouble getting back to being the screen sharer at the end. So I wanted to talk a little bit about cancer survivorship because there's an estimated 18.6 million cancer survivors in the US today. That means that these people are living with the side effects of their cancer treatment and the potential for cancer recurrence. And so how can they live a better life after cancer with the side effects of their cancer treatment? And I wanted to highlight a Trinity Health survivorship program, which uses a lifestyle medicine approach for cancer survivorship. They are looking at the pillars of lifestyle medicine, which include exercise, sleep, avoiding risky substances, social connection, healthy diet, and there's one more that I can never remember, but really living a healthy lifestyle. And it's well known that staying lean and exercising reduces the risk of breast cancer recurrence after treatment. So this is a very valuable and useful approach for people after both breast cancer and other other types of cancer. And in the chat, Allison will be placing some other resources for cancer survivorship programs from the Cancer Support Community, which is one of our regional partners here in Southeast Michigan, the American Cancer Society, and the Sisters Network, which are all focused on maximizing the quality and quantity of life after a breast cancer diagnosis. That concludes my part of the presentation. I'll turn it over to Dr. Takiar, who is one of our wonderful medical oncologists here at Trinity Health IHA Medical Group. And she practices in Ann Arbor and Chelsea, and is a part of our group in our weekly tumor boards and in our multidisciplinary our multi-specialty clinic on Fridays.
Thank you, Dr. Breslin. I'm going to go ahead and share my screen if you're done. Yeah, thanks. All right, can you guys see my screen okay?
Yes.
Okay, perfect. And it's not the presenter view? Okay. So thank you for the introduction. As you guys have probably heard, my name is Radhika Takiar. I'm one of the medical oncologists here at IHA. I did a large part of my training locally at University of Michigan. Unlike Dr. Breslin, I'm a little bit early on in my career, but have been here at Trinity Health for the past 2 years. So my role is as a medical oncologist, and I'll sort of be giving some updates in breast cancer from that realm. So a brief outline, I'll be talking a little bit about, pathology and the different types of breast cancer, and then also speaking to what my role as a medical oncologist is. We'll talk a little bit about anti-estrogen treatments and then some updates in early stage breast cancer and also sort of what's new and coming in breast cancer since there's been a lot of changes and new medications in the horizon. Sort of as Dr. Breslin, alluded to, there's sort of different phases of how cancer originates. The way that, I think about it is that we all have cells that are rapidly dividing and growing, and sometimes there can be mistakes in these cells. And when that happens, usually our body has a way of correcting those mistakes. The problem comes when those mistakes are not corrected, and that allows these cells to kind of grow unchecked. And so, as you can sort of see in this progression, what can start as some atypical cells in the breast duct, called atypical ductal hyperplasia, can grow and become this DCIS or ductal carcinoma in situ. So it's still contained within the duct. And then once that learns to go outside of the breast duct is when it becomes the invasive breast cancer. So generally, when we think about breast cancers, I divide them into a couple categories. There are those that are estrogen positive, so often driven by the estrogen in our bodies. And the backbone of treatment for these are anti-estrogen based oral treatments. There are HER2 positive breast cancers, so these are often driven by a protein called HER2/neu. And the backbone of treatment for this is targeting that protein and then also typically involves some type of chemotherapy. And then there's triple negative. And what that means is that there is really no evidence of that estrogen, progesterone, or HER2 protein on these cells. And so there's really nothing to target. And for that reason, we are often using things like chemotherapy and immunotherapy, which I'll talk about a little bit later for that. This is a figure mostly just to show how complicated each different type of breast cancer is and how, because there's so many differences in these pathways, we treat them very differently. So, left to right, it's estrogen positive, the HER2 positive, and triple negative. And these are, pathways at the molecular level, and you can just kind of see that they look very different. And so that's why we have to think about them differently. There are some pathways that are shared among these, and there can be some overlap in treatments, but we do need to kind of think of them distinctly. So, a common question that we get in our clinics is, well, I did surgery. Dr. Breslin you got negative margins. Like, why do we need to do anything else? And so the purpose of adjuvant treatment, so treatment that is after surgery, is often to prevent future breast cancer recurrences. And this could be to prevent the breast cancer coming back in the other breast, to prevent breast cancer coming back somewhere else in the body as like a stage 4 breast cancer, and to improve long-term outcomes, because we do know that if it comes back as a stage 4 breast cancer, that does affect our mortalities. And so a large part of the discussions that we have in clinic are in regards to other medications. So things like chemotherapy and immunotherapy that you get in the infusion center, anti-estrogen treatments, which are pills that can be taken at home. And nowadays we have a lot of targeted treatments as well. And the thought being that, even though at surgery we're kind of getting rid of the breast cancer itself, could there be some microscopic cells that are hiding out somewhere else? And are those going to kind of proliferate or grow in the future and lead to another breast cancer? And so that's partly why a lot of this is being done. So, to touch a little bit on anti-estrogen based treatment, there's sort of two big categories of what we use for this. One is a medication called tamoxifen. So tamoxifen, what it's doing is it's basically kind of like a guard and preventing that estrogen from affecting the cells. And then there's what we call aromatase inhibitors. And so it's blocking an enzyme that's responsible for converting things like testosterone and androgens into estrogen. And there's three different types that I've listed here. Anastrozole or Arimidex, letrozole and Femara, and then exemestane and aromasin. So they work, slightly differently. As we get older, our ovaries don't, make estrogen anymore. However, the body still has this mechanism of creating estrogen. And then the whole purpose of doing these aromatase inhibitors is to block that production. And what we've found over the years is that using these anti-estrogen treatments is effective in reducing the recurrence rates for estrogen-positive breast cancers. And it does a pretty good job of that by taking whatever someone's individual risk is and decreasing that by nearly like 40%. One question that, we get asked a lot as well is, well, what's the difference and why do we pick one over the other? A large part of this does depend on, if women are pre or postmenopausal. Um, there's been some studies that have shown that when comparing tamoxifen, which is this red line here, and these aromatase inhibitors, which is the blue line here, that outcomes are better in terms of preventing a recurrence or affecting our mortality from breast cancer with the use of the aromatase inhibitors, particularly in our postmenopausal women. So that's often why we're using those first before using tamoxifen. So, talking a little bit about the new kid on the block. So, there's been these drugs called CDK4/6 inhibitors. The way to think about it is that there's something called the cell cycle, and this is basically sort of how cells are growing and proliferating. And so this drug basically blocks this cycle. And so when that happens, it puts the cells into an arrest, and these cells then die. And so these drugs have been around for stage 4 breast cancers that are estrogen positive and have been very effective. And so there's been recent studies that have been trying to incorporate these drugs into more advanced, like stage 2 and 3 breast cancers, and have found that they are also helping reduce the recurrence rates using them early on. So these are two of those medications, which you may see commercials about nowadays. So the abemaciclib or Verzenio, and the other one being ribociclib or Kisqali. These are both oral medications. They're taken slightly differently. The Verzenio is twice daily and it's taken with endocrine therapy because that's how it was studied. And then there's Kisqali, which is taken 3 weeks in a row with 1 week off. They're different durations, and a large part of that is just because that's how they were studied in the clinical trials. So Verzenio is for 2 years and the Kisqali is for 3. And what they found is that by using these, we have been able to reduce the likelihood of the breast cancer from coming back both locally in the breast or the lymph nodes or as a stage 4 breast cancer by nearly about 5 to 7%. These do come with some side effects of decreasing blood counts. The Verzenio tends to cause more things like diarrhea and fatigue. And then the Kisqali can affect certain things on an EKG, which we monitor. But we've been incorporating them, in stage 2 and 3 breast cancers, depending on each individual patient's kind of features of their breast cancer. Another question that I think is very relevant and important is, who needs chemotherapy in estrogen positive breast cancers? The answer is that not everybody will need chemotherapy. And the reason is because we have done 2 clinical trials in the past that have basically established the role of this oncotype test. What this is a test that kind of looks at the high risk features within the breast cancer, the pathology, and gives us a number. The higher the number, the more likely someone is going to benefit from chemotherapy. So I know it's a little bit small on the slide here, but women who have a score of 26 or higher are the ones who are deriving a lot of benefit from chemotherapy. Women older than 50 whose score is less than that, there's really no added benefit in chemotherapy. And then women who are younger than 50, for the most part, their score being less than 25, there's really no benefit, though there is a little bit of a gray zone, and that's often a discussion that we have in clinic. So, current areas that are actively being investigated and studied. One is this question of, can we get away with less? And so, tamoxifen, there's been data with that using it at a lower dose. So, can we get away with a lower dose that's taken every other day because we know it's better tolerated? So we actually have a clinical trial at Trinity Health that basically is trying to answer that question in postmenopausal women who have small breast cancers. And it basically randomizes them to one group gets the low dose and the other group gets the standard. We don't know what the results are yet, but the whole point being is the lower dose equally as effective? And, can we get away with, less side effects? The other question is chemotherapy even needed? In premenopausal women, there are certain categories who often we are automatically giving them chemotherapy for. And what we don't know is the benefit from chemotherapy coming because of the fact that it's killing cancer cells, or is it because we're putting these younger women into an early menopause? So we also have a trial that's a national trial asking that question of, can we do chemotherapy or do we need to do chemotherapy or could we just get away with the anti-estrogen treatments? So switching gears a little bit to talk about HER2 positive breast cancers, size and lymph node do matter as it affects how we sequence treatment. Generally speaking, smaller breast cancers that don't have lymph nodes, we send them to surgery first, and then we give them some chemotherapy and targeted treatment on the back end. Tumors that are larger or have lymph nodes involved, we're often doing chemotherapy first, followed by surgery, and then potentially more treatment on the back end, and that'll depend on how the response is at the time of surgery. The reason we're doing this and the reason it matters is this question of pathologic complete response. What that means is that at time of surgery, after someone has gotten some type of chemotherapy, what we hope to see is that there is no cancer left behind. So similar to what Dr. Breslin had sort of mentioned, what we hope for is that, patients fall into that 40 to 60% category where there is no cancer left behind at the time of surgery. Because what we know is that women who don't have any cancer left behind at the time of surgery tend to do better in the long term. The other thing it helps us with is to determine what treatment do they need after surgery. I just wanted to touch on some new advancements for HER2 positive breast cancer. There's a lot of new drugs that are being used that have been very effective. One particular drug is what we call an antibody drug conjugate. What this is basically this drug targets a protein, and then the chemotherapy gets released in the cancer cell. And so the thought being that instead of sort of just going around without, targeting or having it has more of a specific kind of tumor kill effect. And so this drug has been very effective. And actually, there's a clinical trial that's been studying it in stage 4 breast cancers as the frontline agent. And as of right now, it hasn't changed the current standard of care, but this might be changing based on how well it's doing. And then switching gears to talk a little bit about triple negative breast cancer. And so similar to HER2 positive, the size and lymph node status matters. Um, there's really no targets that we have to use to target, this triple negative. And so for a long time, we have just been using chemotherapy. However, immunotherapy has also been found to be effective. So this is pembrolizumab, where you may hear commercials about Keytruda. So there was a study where they combined chemotherapy with the Keytruda, and then patients went to surgery. And then after surgery, if there was a complete response, they got some more Keytruda, versus if they didn't, then we gave them a different type of chemotherapy. So the way that Keytruda or these immunotherapy drugs work is that they use your body's immune system to kill the cancer cells. So this red triangle here is the immunotherapy, and what it's allowing the body's immune system, which is this T cell, to do is basically help kill that tumor cell. And this is just some data from the clinical trial, but you can see that the pembrolizumab chemotherapy arm, which is in the yellow, those patients had a improved longevity, and the likelihood of the breast cancer coming back was lower in that group. And then some new treatments in this space are also, again, those antibody drug conjugates. And so they've been also studied in the triple negative setting. And so this might also be changing the landscape for women or men who have stage 4 triple negative breast cancer. In terms of advancements, one question that has come up is, do we need to give immunotherapy after surgery? A large part of the benefit that we're seeing from immunotherapy is coming before surgery, but is that additional treatment after adding a whole lot? And so there was a clinical trial that I think recently just closed that will hopefully answer that question. There's also another one where we're trying to get away with less chemotherapy and hoping to attain similar outcomes that we also have available here at Trinity Health. So I just wanted to briefly highlight that, I think a large part of breast cancer is, the clinical trials are key to advancing this field and coming up with better treatments that are effective and come with less side effects. Here at Trinity Health, we are the home of the Michigan Cancer Research Consortium. We are one of the top 5 funded programs nationally and have several clinical trials, not only looking at treatment, but survivorship, symptom management, and prevention. So with that, I will also kind of highlight that, 1 in 8 women get affected with breast cancer in their lifetime. But as you saw with Dr. Breslin's talk, we have many breast cancer survivors.
Thank you all for listening, and I think now we will take questions.
Is it still normal to remove the breast?
So I can take that question. There are certain situations where we are technically unable to preserve the breast. And so those would be a situation where the extent of the tumor extends across two quadrants or is too large to allow breast conservation without really deforming the shape or appearance of the breast. There are certain types of breast cancer, such as inflammatory breast cancer, where the standard of care is still to do a mastectomy for the therapy. And lastly, there are people who are diagnosed with breast cancer, and then either they already know about it or they're later diagnosed with an inherited predisposition to breast cancer, such as a abnormal BRCA1 or BRCA2 gene. And many of those patients, even if they are a candidate for breast conservation, might choose mastectomy, although I have many patients who are BRCA1 and 2 carriers who still decide to have breast conservation because they would rather not have a mastectomy.
Okay. And if you have a question to ask, please feel free to drop it into the Q&A feature at the bottom of your Zoom screen at any point while we're answering these questions. Okay, so there's a question about AI imaging for detection of breast cancer. Can you expand on that just a little bit?
I think that one is probably a better question for one of our radiologists. I know that radiologists have for a long time been using computer-assisted detection as a part of mammography. And so the images are looked at both with the CAD and by a real live radiologist. I think that that's about as far as I can go in terms of really understanding or describing the technology.
Okay.
Yeah, I agree. I don't really have much more to add. I think it's something that might be coming in the future, but yeah, I'm not sure where we're at with that.
Okay, it sounds like it might be a mix at this point, but it's best to chat with a radiologist. Okay. This person is wondering if you have any new information about the difference between invasive ductal carcinoma and invasive lobular carcinoma. And I think they're looking for treatment options, and I might be saying that wrong, lobular. And if there are treatment options that make a difference in spreading. Does that make sense?
Yeah, I can talk a little bit about that. So yes, there is a little bit of a difference in kind of where the breast cancer is originating, whether that's within the duct or within the lobule. In regards to treatment, often the way we're treating is more based on the receptor status and not necessarily whether it's ductal or lobular. What we know is that, typically the way lobular breast cancers tend to spread, it's more in a linear fashion as opposed to like a mass. So these women are often getting like an MRI, for example, to make sure we're capturing the extent of disease. Um, and then, I think the main thing being that these are also not typically as chemosensitive. And so on that oncotype score, it might be low if it's a lobular, but that's not always a guarantee. But I think in terms of treatment decision, it still largely depends on the size, lymph node involvement, and then the exact kind of receptor status.
Okay. All right, and this is another question for Dr. Takiar. So with ER and PR and breast cancer, how do you decide between giving a patient
Tamoxifen, yeah.
tamoxifen, thank you, or an AI? Is that what that?
And
Yeah.
AI, yeah.
Okay,
Um,
sorry.
you got it. Thanks. Yeah, so often women who are premenopausal are getting tamoxifen because their ovaries are still making estrogen, and so we need to block the estrogen from binding at the level of the receptor. However, there are certain premenopausal women who may have higher risk disease, and they are getting the AIs or aromatase inhibitors, with an injection that suppresses their ovaries. Postmenopausal women, either is an option because their ovaries are no longer making estrogen. The preference is typically more for the aromatase inhibitors just because we do know they work a little bit better than tamoxifen.
Okay. And what are the chances of getting breast cancer in the other breast after having it in one?
So that's the $64 million question in my practice. And in general, the risk of developing another breast cancer on the opposite side is 1 to 2% per year on the other side. Unless you have one of the cancer predisposing conditions. And many people ask this question in the context of whether they should undergo bilateral mastectomy or remove both breasts for a single breast cancer. And that's a very individual and personal decision, and we spend a lot of time talking about that.
Okay.
I actually had a patient who wrote a book about it. And in one of the chapters, she said, as usual, I came to clinic and Breslin was no help. So it's not an easy decision.
Yeah, I imagine. Okay, what is treatment after lumpectomy if you had both high nuclear grade DCIS totally removed with extra margins and also ALH removed? Is active surveillance better than radiation?
So I can take that one. We can really kind of there's sort of two ways to look at that. One is to look at the data from the COMET study. And high grade DCIS was excluded from that study. So it had to be either grade 1 or grade 2 DCIS in order to be included. And so that wouldn't really meet the criteria for this one, for this question. But there is another test that some people use called Oncotype DCIS, and that looks again at the tumor tissue and helps in some cases make the decision about radiation. We tend to have a stronger recommendation for radiation therapy in women with grade 3 DCIS, even when the margins are clear.
Okay, and thank you for bearing with me while I struggle through some of these. This audience is much smarter than I am, so I appreciate your patience. Okay. Which drug has better outcomes for perimenopausal women with estrogen positive cancer?
Yeah, that's often a tricky space to be in. I think that technically speaking, women who are still having menstrual cycles, we have to use tamoxifen because their ovaries are still making estrogen. However, over time, they're likely to stop, and so often we'll switch them over to the aromatase inhibitor. But yeah, it's very much kind of patient dependent and kind of depends on where their perimenopausal status is exactly at. But it's a little bit of a gray zone.
Okay. Is there any evidence that high stress can cause breast cancer? I've noticed at least 7 women diagnosed very soon after becoming widows. So wondering if caretaking or stress can contribute to breast cancer diagnosis.
I mean, I don't know of any like good research to support that. I mean, I think we all wonder and ask ourselves that question. I don't know of off the top of my head that that's specifically a risk factor. I don't know if you do, Dr. Breslin.
Yeah. So anecdotally, in my practice, it's a pretty common observation actually to have a patient come to me after a significant life stress. And often it seems to be that, yes, that situation was very stressful and they weren't sleeping well and they weren't eating well. And they also just didn't have time for self-care and screening tests. And so when their loved one finally does pass away, then they are able to turn their attention back to their own health and get tested for colon cancer and screen for breast cancer. So these things sort of tend to come along at the same phase of life. And it's unlikely that, a year or two or 6 months of caregiving would be a strong enough stimulus to cause somebody to develop breast cancer from that event alone. But it's the cumulative effects of stress, a stressful lifestyle, which may contribute to breast cancer risk.
Okay. And does the size of a woman's breast put her at higher risk?
It does not. Um, yeah.
Is there a change in risk in terms of like feeling a tumor sooner? Like if you have a smaller breast, you might see it sooner versus a larger breast. Is that something that you ever see?
Well, most women are diagnosed with small tumors through screening mammography, and ductal carcinoma in situ or pre-stage 0 cancer is almost, usually not palpable. Occasionally, it's associated with the mass, but most breast cancers aren't palpable, no matter what the patient's breast size is. Younger women tend to present more often with palpable breast cancers because they may be younger than the age that they would start screening mammography. Um, and sometimes we'll notice patients who have lost significant amounts of weight suddenly notice a breast cancer that may have been masked by a larger breast.
Okay. And I believe you talked a little bit about genetics. Is genetic testing of value if you have a family history of breast cancer?
So in many cases, yes, we use certain criteria to determine whether or not somebody is high or low risk for having an inherited predisposition for breast cancer. So that triple negative breast cancer that Dr. Takiar mentioned, regardless of family history, we would recommend genetic testing because that population of patients is more likely to carry one of the breast cancer associated abnormal genes. And people with a strong family history, multiple relatives, and premenopausal breast cancer, as well as a family history of ovarian cancer, pancreatic cancer, and melanoma.
Okay. If you are triple plus, is there benefit to stay on AI up to 10 years?
I don't think that the studies that looked at extended endocrine therapy like that were primarily for those that were estrogen positive and probably HER2 negative. So I don't think there is good data that those women need to be on 10 years because I think a large part of the benefit is coming for those that were truly just estrogen positive and not triple positive.
Okay. And what is the main safety concern with regular dose tamoxifen anticipated to be diminished by the LOTAM trial study objective?
If I'm understanding the question correctly, so they're asking about like
The main,
efficacy.
the main safety concern with the regular dose tamoxifen and then anticipated to be diminished and then by LOTAM trial study objective.
So the purpose of the study is to evaluate whether lower dose tamoxifen is equally as effective as the standard of care, which is the normal dosing. We do know that lower dose tamoxifen comes with less side effects. What we don't know is it as equally as effective at preventing a breast cancer recurrence? Um, in terms of the side effects, these are side effects of menopause, so things like hot flashes, kind of joint stiffness, vaginal dryness, mood changes, can happen with these medications. And so historically, based on evidence and research, we and just seeing this in patients, low dose tamoxifen is just easier to tolerate, which we know we're just trying to see is it as good.
Okay. Would you comment about how mRNA vaccines can synergize with immunotherapy to improve outcomes?
I'm not sure I'm not totally familiar with this question. I know there was maybe a recent publication about this. I haven't read it in detail. I think there was something about the COVID vaccine and immunotherapy. Um, but I don't know the specifics off the top of my head.
Okay. This person says, what about radiation? Oops, sorry, I muted myself again. What about radiation after surgery? I'm not sure.
Yeah, well, there's a couple of scenarios when radiation is recommended after breast surgery. The first scenario would be after breast conserving surgery to reduce the risk of local recurrence. And there are a couple of different ways to give radiation. There's sort of whole breast radiation, and then there's partial breast radiation, which tends to be a shorter course. Um, and Then the other scenarios where we use radiation after breast surgery are for patients who have mastectomy and have positive lymph nodes. There's a survival advantage, meaning people live longer after treatment, after mastectomy, if they also have radiation therapy. And then the last place that we use radiation is for patients with symptomatic metastases. Typically, it's for bone metastases, but occasionally for brain metastases as well.
Okay. Is hormonal therapy not allowed for menopause symptoms for DCIS patients?
So typically, if the DCIS is estrogen positive, those are the women that would qualify for an anti-estrogen based treatment. So in that situation, yes, would not recommend hormone replacement therapy. Um, in women who are DCIS, who are estrogen receptor negative, there's no strong kind of contraindication, though it's often a little bit of a discussion because having DCIS does put them at higher risk of another breast cancer or DCIS in the future. And so it's sort of a risk benefit discussion.
We often do compromise somewhat, though, in patients who have symptoms of urogenital atrophy or vaginal dryness and urinary frequency. And many of those patients who have low risk breast cancer and are, for example, postmenopausal on an aromatase inhibitor may be candidates for low dose topical estrogen to help with urogenital atrophy. The other situation where hormone replacement therapy might be appropriate in a patient with DCIS is if they undergo bilateral mastectomies, because the anti-estrogen therapy is given in the prevention setting, and the surgical therapy has already done all of the prevention.
Okay. If you have dense breasts, are there any additional tests besides, it says a tommogram?
Yes. About 50% of women have dense breasts. There's 4 categories, A, B, C, and D. And 50% of women are category C and category D, meaning that they might benefit from some supplemental screening. And at Trinity Health, the supplemental screening option that we have is rapid protocol MRI, which is a breast MRI that's given, that takes about 15 minutes as opposed to 45 minutes for a standard protocol MRI. The downside of supplemental screening is that although many women will get that letter saying that they have dense breasts, insurance doesn't necessarily cover supplemental screening. So the rapid protocol MRI is a really high quality study, which is an out-of-pocket study. There are other technologies such as whole breast ultrasound, molecular breast imaging, which other health systems in the region have utilized.
Okay. There are several questions about AI. So how long do the side effects last after stopping? And can you stop too soon? We talked about 10 years, but can you stop at a point that's not, that's too soon?
So typically the standard is 5 years. There are some patients who will qualify for 10 years if they have bigger breast cancers or several lymph nodes involved, but the standard is 5. In terms of side effects, often, stopping it after 2 to 4 weeks, the side effects that women may be having will substantially decrease. And often we're having to kind of switch between the different types. Nearly 40% of the time, switching from one to another, actually, women tolerate the other one better. So it does take some trial and error. But yeah, many of the side effects are very quickly kind of reversible. The issue is that some side effects are kind of predating the aromatase inhibitors or the AIs. So like arthritis and, depression and stuff like that, if that's already there, it can make it worse. But the initial, arthritis and depression that was there before, that might not completely go away.
Okay. And there are a couple questions about fibroids. One, do they ever lead to cancer? And is there any evidence that having a hysterectomy, keeping the ovaries, because of fibroids, is there any evidence that removing or having a hysterectomy can lead to estrogen positive cancer?
I mean, I think in regards to fibroids, I don't think that itself is a risk factor for breast cancer. There are women with the BRCA1 or 2 mutation who, if they have that, then we sometimes will recommend kind of a risk reducing kind of removal of the ovaries. And then I think the third part of that was if a hysterectomy leads to increased risk of breast cancer, which I don't think that that is true.
Okay.
It's more common that all of these conditions occur in similar aged women. And so they may happen around the same time of life, or, many of my patients have had breast cancer and a hysterectomy and fibroids, sort of all occurring in the same person.
Okay. Okay. Does IDC with 2 masses, grade 2, always result in a lumpectomy?
Um, so I think the question is asking, can you have a lumpectomy if you have more than one tumor? And the original studies that looked at whether it was safe to do breast conserving surgery, meaning just as good as a mastectomy, all required women to have just one tumor. More recently, there have been some smaller studies that ask the question, can we do 2 lumpectomies in the same breast, in the same individual? And it seems to be safe, meaning low rates of recurrence in the breast. If the tumors are small and fairly far apart, if they're too close together, the 2 surgical sites either need to be encompassed into one, and so as long as that doesn't make too large of a defect in the breast, it's certainly feasible.
Okay. And then there's a little bit of a correction on my question before this. So do fibroids in the breast lead to cancer?
Oh, so fibroadenomas. So fibroadenomas are benign tumors that tend to happen in young women in their teens, up to 40s and 50s. And they are not known to increase the risk of breast cancer. But because they have glandular tissue in it, so it's called a fibro, meaning connective tissue, adenoma, meaning made of the glandular part of the breast, a breast cancer could potentially arise from the adenoma portion of the fibroadenoma. But fibroadenomas in and of themselves don't increase the risk for developing breast cancer.
Okay. Is infiltrative ductal carcinoma grade 1 the same thing as DCIS?
No, I mean, I think that would, one is an invasive, kind of has escaped the duct, and the other one is still contained within.
Okay. Someone is asking about mammograms. Has the technology improved and how accurate are they in identifying an issue?
So the technology's changed quite a bit over the last 20 to 25 years. We've gone from film screen mammograms, where they actually kind of took a photograph and using an X-ray machine and printed it out on a piece of plastic and put it up on the X-ray screen, to digital mammography, which allowed for storage of multiple years and comparison of rapid comparison of multiple views, to now doing tomosynthesis, which not only allows us to have same standard views, but it actually allows the radiologist to see multiple views in each plane through the breast. And so you think of it almost as sort of looking at the breast in slices. And so that technology, the tomosynthesis or 3D mammogram, has increased the cancer detection rate, so that we are identifying smaller and smaller tumors. Some would question if we are over detecting breast cancer and maybe detecting some cancers that might not ever need treatment. And that's sort of why the DCIS study was undertaken, is there some DCIS that doesn't need full court cancer treatment with lumpectomy and radiation?
Okay. And is there an explanation why Black males with breast cancer have a much lower survival rate?
It I'm sure it's multifactorial, just like anything. Men in general tend to present with later stages of breast cancer because they don't have screening mammography. And in the same way that Black women don't have the same survival as white American women, that is thought to be later diagnosis and maybe less acceptance or utilization or access to multidisciplinary care, and high quality cancer care in tertiary type of institutions.
Okay. Someone is asking if the region or your geography weighs into your diagnosis. So is it likely that women living far from a hospital are not being diagnosed, or could there be a reason why the incidence of breast cancer is larger in more populated areas?
Well, there are, obviously more people in populated areas, which would give you a higher number of people being diagnosed. There's also just more screening facilities. And so what you don't test for, you don't know about. And here you can, within Ann Arbor, there are probably 5 or 6 screening mammography facilities across different clinic locations and hospitals. And that leads to a higher incidence in a way because more people are being screened. Whereas if you live in the eastern upper peninsula of Michigan, there may only be 2 or 3 screening facilities across that whole, 4-hour drive, leading people to have less screening. And there are also differences in exposures in urban versus rural environments.
Okay. And we are at about 8:15. There's a handful of questions left. Are you okay to hang out for a few more minutes?
Sure.
Cool. Okay.
Sure.
Okay. This question, and I'm probably going to butcher this, so bear with me. So has a study been done to measure long-term outcomes of prophylactic mastectomy in the unaffected breast versus no prophylactic mastectomy, i.e., is reoccurrence less probable for those with prophylactic mastectomy on the contralateral side?
So the only group where removing the opposite breast or the contralateral breast has been shown to be beneficial in terms of survival. There are other outcomes besides survival. Cosmesis, meaning the appearance, patient preference, that are also important and go into a patient's decision when they're deciding about this. But there has not been a study that demonstrates an improvement in survival with contralateral prophylactic mastectomy, except in the situations with, BRCA1 or 2 or some of the other high-risk genetic conditions.
Okay. I will wrap up with this one last question. Is there a safety concern regarding estradiol or PTNS treatment? Does that make sense?
I'm not quite sure I understand the question. Um,
Is there a safety concern regarding estradiol? I don't know if I'm saying that right. Estradiol.
yeah, so I mean, I guess what I'm interpreting from that is like hormone replacement therapy. We do know that that is a risk factor, for breast cancer, kind of at like early menstrual cycles, late menopause, use of hormone replacement therapy, all of these. Um, but I mean, I think it's just a risk factor. It's not enough that we're, not recommending it for women who have menopausal symptoms that may require treatment.
Okay. And this last question, do you recommend oophorectomy surgery for estrogen positive postmenopausal breast cancer patients?
I think we sort of talked about this a little bit earlier, but the situations where that would be recommended is for someone who has a BRCA1 or 2 mutation, because they're at higher risk of ovarian cancer.
Okay. All right. So with that, that brings us to the end of the Wednesday Wellness webinar. So thank you so much for those of you who are hanging in there through the Q&A. We covered a lot of information, so we hope you're walking away with a deeper understanding of the complexities surrounding breast cancer and treatment. So I want to extend a huge thank you to our speakers for sharing their expertise and to all of you for your thoughtful questions. Before we wrap up, there's a quick reminder. We'll be sending out a follow-up email with a link to the recording and some additional resources that were mentioned today. So again, thank you for being here, and we hope to see you at the next Wednesday Wellness. And thank you so much to our presenters for being here. Have a good evening.